Well, good morning. Good morning. Good morning. Okay, that's better. Thank you. Um, I'm so glad you guys are here. And many of you know we have had, River Landing has had a partnership with Hospice of the Piedmont for I don't even know how long, but a long time. And Hospice, of course, has an amazing reputation, especially this organization of hospice. And our experience with them has only been good. And you all, many times, residents have asked me a lot of questions about what does it look like and what's the difference between hospice care and palliative care and when do I know I need that and what's the process. And so I'm delighted this morning to introduce Joanne Scott, who is an RN and has been with Hospice of the Piedmont for 25 years. And she's going to share with you an overview, and then I'm sure we'll take maybe questions at the end. So I'm going to introduce her. Y'all help me welcome Joanne.
Thank you so much, Cindy. I just can't tell you how grateful I am for the opportunity to speak to you today. I have to say that your neighbor that's sitting right amongst you, Judy Frazier, hired me at Hospice of the Piedmont 25 years ago, and I have never looked back. She's the best boss I ever had, and it has been a privilege to be a hospice nurse for over 2 decades now. And when I first started, I was a case manager nurse, and I was the nurse for River Landing. So this place, the heart of the staff here, the spirit of the residents here, you all hold a very special place in my heart. So it's good to be here talking to all of you. And I am going to be talking today a little bit about the differences and the similarities between palliative care and hospice. I've titled my speech, Life at its Fullest, Beginning to End, because as we all know, I'm not getting any younger, and I'm sure you aren't either. And we can live life quite fully all the way through the continuum. See if I can operate the technology of all this. I loved, as I was preparing this talk today, I loved this sort of definition of living life at its fullest. Living life at its fullest means intentionally, passionately, and actively pursuing a purposeful life, maximizing personal potential, and savoring both joyful and challenging experiences without regret. That sounds wonderful. And we truly can do those things from the beginning, in the middle, and as we near the end of our lives. I love this quote by Cicely Saunders. We're going to learn a little bit more about her and what she has to do with all of this. But she said, "You matter because you are you, and you matter to the end of your life." As long as we have breath in our lungs and our heart is beating, we are very much alive. And what I'm hoping today is that as I speak to you about both of these services, you might see them as tools to help you along the way to live your life as fully and comfortably and as supported as possible. So what is the difference between palliative care and hospice care? And I always say to people, it's easier for me to explain the difference when I start on the hospice side and we kind of work our way backwards. So that's what we're going to do today. I think it's a little bit easier to understand if we do it that way. So I wanted to talk a little bit about the origins of hospice, how in the world it came to be. The word hospice is derived from the Latin word hospes, meaning guest or host, or hospitum, meaning hospitality. And at its earliest roots, prior to the 20th century, hospices were simply places of hospitality where weary travelers could gather and rest. And it was around World War II in the 30s and 40s, 1930s and 40s, where Cicely Saunders, who we just heard that quote from, who was an English nurse, was training in her nursing field, and she became sort of on fire through her experiences in crusading this sort of movement, highlighting the desperate need to try to improve better symptom management and end of life. She went on to become a doctor to enable her to better serve her mission, which was comfort care. And it was in the 1960s that she created the very first formal hospice. It was called St. Christopher's, and it was located in London. And the focus of care there was care towards all three, the mind, body, and spirit of each patient. So around that same time, Cicely Saunders visited Yale University. She made her way across the pond and started to introduce her ideas and lectured to a group of medical students, nurses, and social workers, and chaplains. And things started to really take hold there. The movement started to gain momentum around that time. And the dean of the School of Nursing at Yale, Florence Wald, ended up taking a sabbatical from her position at Yale and traveled over to train and work at St. Christopher's Hospice in London. And then it was around the 1970s that Florence Wald came back to the States, and she, along with two physicians and a chaplain, founded the very first hospice stateside, and its name was Connecticut Hospice. It was located in Branford, Connecticut. So at that time, all hospice care was administered by nonprofit organizations and volunteers that were really just dedicated to this sort of grassroots effort and this movement. It wasn't until 1982 that Congress decided to pass that hospice care could in fact be added to the Medicare benefit structure, and that took effect November the 1st in 1983. So now all the wonderful Medicare beneficiaries in our country under their Part A Medicare benefit have hospice services as a service that you can elect when the time is right for comfort and supportive care. So I thought this was interesting, and Judy might find it interesting as well. When I started hospice 25 years ago, we were still very much trying to help the community understand what we did. And we're still doing that a little bit, but we've come a long way. And so we have some statistics now. The hospice statistics tend to lag a little bit, but we have some statistics from 2024 that tell us that 1.91 million Medicare beneficiaries were enrolled in hospice care for one or more days. And for the first time in history, in 2024, over half of the Medicare benefit population received hospice care at time of death. So that's interesting change of events. We, up until 2024, we were still working very hard to help Medicare beneficiaries understand this free benefit that is housed under their Part A that they could take advantage of. And now we're starting to see the momentum is growing and people are exercising their ability to utilize this wonderful benefit. So that was exciting to me to see that we're starting to change some hearts and minds out there a little bit. You might find it interesting, I'll sort of back up for a minute, when the volunteer hospices were sort of emerging in our country prior to hospice being added to the Medicare benefit, you would often hear hospice used synonymously with cancer care. Cancer tended to be the primary diagnosis that hospice would serve at that time. But you can see now that we have a tremendous shift, and cancer is the number 3 diagnosis that we as hospice providers across the country serve. Our top diagnosis at enrollment with hospice are cardiac and circulatory issues. That's probably not a surprise to you. The second is neurovascular, And our dementia diagnoses would fall under that umbrella. And then third, you'll see cancer situated there. Fourth is respiratory illnesses, and fifth is kidney disease. And there are many, many other types of illnesses that one might be admitted to hospice for, but those were the top 5 diagnoses or categories of diagnoses served by hospice organizations to the population in 2024. So I'll digress just a minute to say that as more and more folks are using their hospice Medicare benefit, you can imagine that Medicare is paying a lot more money for hospice care. And anytime Medicare is paying a lot of money for something, they have to sort of get involved to help us understand what the criteria are to make sure we're getting the right hospice patients at the right time. And so they have gone to great lengths to give us some guidelines for certain diagnoses. And we as hospice experts, we know these guidelines. So if one were to have any of the diagnoses listed on this screen here, Medicare's going to have something to say about what sort of, where you are in that illness as it relates to the timing of electing your hospice Medicare benefit. And that is what your hospice experts, we have to become experts in understanding those guidelines, those Medicare guidelines, as we interact with patients and families in the community. So what about hospice? How do we know when the time is right to elect the hospice Medicare benefit for ourselves or for someone we love? And I'll say for just a quick minute, you'll hear me say the hospice Medicare benefit a lot because Medicare is sort of the gold standard of what hospice care looks like and how it is delivered. But you will find that those who receive Medicaid services or are on commercial private insurance policies, their hospice coverage greatly mimics Medicare in most cases. And so as I refer to the hospice Medicare benefit, you will find that across the board, the hospice benefit, no matter the payer source, is generally the same. What Medicare would say for hospice patients is you sort of have to have the both and the and, not the either or. So you would need to both be believed to have a prognosis of 6 months or less with your illness or your hospice condition, and you have to have elected not to receive aggressive curative treatment of that illness. It's sort of a departure from the treatment wheel that you can sometimes find yourself on, and sort of a little bit of an exit ramp, I call it, more towards a focus on what we can do to add comfort and quality to life. Many people don't know, but these are all of the services that are available under the hospice Medicare benefit. So you will see the patient and the family at the center of that wheel there, and all of the spokes that come off of that wheel, starting at the top and moving clockwise. You will see the patient's personal physician. We strive very hard at Hospice of the Piedmont to keep your community physician involved or at least informed of what is happening with hospice care. You will see that the hospice physician is heavily involved. We at Hospice of the Piedmont, I am proud to say, are a not-for-profit hospice. We are very dedicated to the sort of original grassroots patient-centered focus of hospice care. And we have a wonderful team of providers consisting of physicians and nurse practitioners that help us deliver our services, and they are heavily involved with the care we provide. Of course, our nurses are a big, big piece of the chain of hospice care. We have our advanced practice professionals, as I mentioned, nurse practitioners are the sort of the extenders that we have hired at Hospice of the Piedmont. We have our certified nursing aides who are our wonderful bath and care aides that work with our nursing and social work staff. We have chaplains on staff to help folks navigate the spiritual journey of hospice. We have wonderful bereavement counselors, and I'll press the pause button here just a minute to say, many people don't know this, but as a not-for-profit hospice, our bereavement counselors are working not only with the families of patients we served, but they work heavily in the community with people who are grieving and bereaved, regardless of whether we served their dying loved one or not. And those services are completely free to the public. And you'll see on the table here, we have a myriad of bereavement opportunities, ways that folks can get engaged with our bereavement team for support if you are grieving. And we encourage folks to do that at free of charge. And moving along the spoke, we have our wonderful social workers who are supporting our patients and families along the way. And then as a Medicare accredited hospice, we are required that 5% of the services we provide must be delivered by volunteers. And so the very people that pour into us, into the community, or that we might have served their loved one, are now giving back to us in amazing ways and working with patients and families. And they go through extensive training, background checks, and they go out and are another sort of leg of the services that we provide, and they have a wonderful ministry of their own, so to speak. So those are all the faces and people that might be involved with you or your loved one if you choose to elect your hospice Medicare benefit. Where can hospice care be provided? Well, sort of the gold standard of hospice care is to meet people in their home. Most people want to be home, and we want to meet folks at home and serve them and their loved ones at home. But we can meet our patients in other places. And so we have wonderful partnerships with long-term care partners, River Landing being one of those very strong partnerships, where we can offer the same sort of complement of services that we do in the home in a long-term care setting, whether that's skilled nursing facility, assisted living facility, or independent living facility. And then, of course, we have 2 hospice units, one at our High Point campus off Westchester Drive, which is an 18-bed facility. It's called Hospice Home at High Point. And we also have a 16-bed unit in Asheboro, in our Asheboro campus off Vision Drive. And those units are highly specialized. We are not licensed for long-term care. We do not compete with our long-term care partners in any way. Those are highly specialized units, short stay units, where we can bring in patients who have more complex symptom management needs that we might otherwise have difficulty caring for in a different setting. And that's how we sort of use those units to triage the more complex patients and care. So why would one choose to elect their hospice benefit? Could you just sort of go along and not do it? You absolutely could. It's completely voluntary. It could never be forced upon you. You get to choose when you want to elect your Part A hospice Medicare benefit. But some of the great reasons to do that when the time is right is that the services are completely free. They are available 24 hours, 7 days a week. They are geared towards home-based support, so we're coming to you. You don't have to come to us. Many times, hospice helps reduce your cost of health care, and we're going to talk about how that might be. And you get truly experts in symptom management, and I can say with full assurance, after all of my experience with Hospice of the Piedmont, that we have some of the finest, most experienced providers with regards to symptom management. Symptom management is not just pain. It can be a lot of different things that cause one to feel uncomfortable, and our team is amazing at helping folks feel better and in some cases live a little longer as a result of that. We have a website that's very interactive and wonderful. And some of the triggers that we sort of targeted questions that we have on the website that get one thinking about the timing of hospice in their own life and their own health journey are the following. Have you had more frequent hospitalizations or ER visits? Been diagnosed with an advanced chronic illness? Had a hard time bouncing back from a medical setback? Had an increase in pain, nausea, breathing problems, or other distressing symptoms? Noticed shortness of breath even when you're at rest? Begun to require extra help with your activities of daily living, your showering, your dressing, all those good things that we do every day? Have you felt a general decline in your overall condition? Have you been diagnosed with advanced or metastatic cancer? Or have you been told by your doctor that your lifespan could be limited? Just one or a couple of these things do not necessarily mean we are at the very end of our lives. But sometimes multiple of these sort of targeted questions get at a bigger picture that suggests that maybe we are. And maybe nobody's talked with us yet about that. And so maybe I need to reach out to my hospice organization and have a conversation. We love conversations. Conversations are never commitments. They're just discussions so that you are armed with and equipped to navigate your own personal journey in the way that feels the best to you. I use this screen a lot when I talk to clinical folks that we partner with, but I think it's also another way of looking at some of those sort of red flags a little bit in terms of our health and our prognosis. I call it the significant 7. If you're having frequent falls, recurrent infections, weight loss, unexpected weight loss, or a decrease in your appetite, some difficulty chewing and swallowing your food or drinking, sleeping more, or starting to feel a little bit confused or turned around, or starting to lose your independence with your activities of daily living, or finding yourself more and more in the hospital. These are clinically significant things that are not dependent on any one diagnosis, but do inform us of how one is doing sort of constitutionally, how they're doing overall in their life and in their health. There are so many misconceptions about hospice, and I find myself sometimes dispelling the myths before we can even start talking about the truths in many cases. And I always welcome those conversations. Some of the more common myths about hospice I've included here. One is hospice medications will hasten my death. That couldn't be further from the truth, especially when you have a really strong, clinically strong team of physicians and nurses that know the comfort medications. They know how to use those in a way that will add to your comfort and your functionality without taking away from your lifespan. And so that's really important to understand. Sometimes hospice feels like I'm giving up, and that could not be the furthest from the truth. There are so many opportunities I think electing hospice affords you. Sometimes it gives you a little permission to step off sort of the treatment conveyor belt and sort of focus more on the things that give you a lot of peace and joy and happiness, and that does not feel like giving up. That feels like getting to it. You must have a do not resuscitate order to be a hospice patient. That's a myth. I can't speak for every hospice, but I can tell you for Hospice of the Piedmont, that is a personal decision and not a requirement to elect your hospice Medicare benefit. I'm going to be stuck in hospice once I sign up for it. And a lot of people feel like we've sort of locked the door and thrown away the key, never to come out again. It truly is an elective benefit. You can elect it or revoke it anytime you choose. And we have had many amazingly large numbers of people that have surprised us and sort of, we call it graduating from hospice, meaning they signed up thinking things were going one direction and things went a lot better than they thought, and they come off of hospice and could come back later if they need to. Hospice is going to stop all of my medications. That's false. And we will talk a little bit more on another slide about just how robust the hospice medication formulary is. And if I sign up for hospice, I can't go back and see my community physician anymore. That's a myth. We try to allow folks to continue to see their community physicians when it makes sense. We don't want them to feel severed from the providers that have sort of cared for them all along. It is important for those providers to know when you've elected your hospice benefit, because your treatment would need to focus more on the comfort sort of side of things. But it doesn't mean you can never go back and see the physicians and providers that you have those relationships with upstream. So I hope that helps, dispel any myths that you might have had coming in today. Okay, here we go. Okay. I love this quote. I don't know if you have ever read the book Being Mortal by Atul Gawande. They also did a documentary on his book. He is a surgeon that had his doctor hat on his whole life, and then his father became ill and passed away, and really shone a light for him on what death and dying looked like. And he wrote a wonderful book about it. And one of my favorite quotes from Dr. Gawande is, "Endings matter, not just for the person, but perhaps even more for the ones left behind." I feel like let me make sure that we're still in order here. Yeah, okay, we skipped that slide, so let's talk about that one. This is the hospice Medicare benefit sort of in a nutshell. We talked about the team that you saw there on the sort of the spokes of the wheel, but there are so many other facets to the hospice Medicare benefit. You have that interdisciplinary team. You also have coverage of any medical equipment that you might need for your day-to-day care. We've partnered with a third party for equipment coverage, and we will pay fully for those equipment items that will add to your functional ability and your comfort. We also, at both of our campus, have what I call a little mini warehouse of medical supplies. And so medical supplies could be something as simple as a Band-Aid all the way up to more complex medical supplies. We have those items in our offices, and we deliver those supplies to the patients that we serve. So those items are covered once you elect your hospice Medicare benefit. And then that medication formulary that we discussed. It is quite robust. We use a third party that manages our pharmaceutical benefits, and there are pages and pages and pages of not only comfort medications, but many other medications for heart health. The sky's the limit. There are multiple medications that you may have found yourself taking for years and years and years that are still on our hospice drug formulary and would be covered in full by the hospice team and the hospice program even after you've elected the hospice Medicare benefit. Those conversations are always held at the time of enrollment. We go through medications with patients and families. We talk about the goals, what's expected of those medications, the pros and the cons of those medications, and we work together to make sure that we're choosing to continue those medicines that make sense for the patient and family, and also for a patient's overall functioning and well-being. I don't know if I'm just really heavy-handed with my trigger finger or what. So I'm just making sure I haven't missed a slide that I wanted to talk about here. I think we're good. Okay. So now I'd love to talk to you a little bit about palliative care. We're going to sort of move a little bit upstream, as I sometimes call it, and talk a little bit about what in the world is it, and why is it so confusing, this issue of hospice and palliative care. I think part of the reason that palliative care is often lumped in with hospice care now is because that's the way it was years ago. Years ago, you would often find in the name of a hospice agency, hospice and palliative care. The words were almost used synonymously. And to make matters worse, it's not only confusing to the general lay public, it's still somewhat confusing to the medical public, to the clinical public. So we're working hard to help folks understand how hospice and palliative care are similar, but how they're also very different. I think it started palliative care, sort of embedded in this hospice movement, and it was around the 1990s that palliative care started to depart from its hospice roots and really truly become a separate and distinct medical subspecialty. When that happened, it truly allowed for palliative care to grow in its own right in the ways that it was similar, but also in the ways it was very different from hospice care. And essentially what I think happened during that departure from hospice is palliative care said, okay, let's think about this. Hospice is getting a lot of things right. They're providing multidisciplinary care. They're keeping folks comfortable and giving them support and better quality of life. There's emerging literature that's suggesting that once folks elect their hospice benefit, they're actually living longer than those with similar illnesses that did not elect their hospice benefit. Something good is happening here. Why are we just hoarding all that good stuff for those who are in their final 6 months of life? Are there tenets of the hospice benefit that we can apply upstream when folks aren't that near end of life, but may truly benefit from it if they're facing chronic or serious illness, not terminal illness, but serious illness? And that's how the diversion began. And so that happened around the 1990s. And so palliative care, as it began to emerge, had to sort of define itself. What are we aiming to do under this subspecialty of palliative care? Who are we serving? What, how, when? And so I've sort of listed it here just to give you a little concept of sort of when we're applying the palliative benefit or services to patients. Usually palliative care is targeting those who have, as I said, serious illness. They're not terminal, but they're dealing with an illness that really can have some challenges day to day, some setbacks here and there, some ebbs and flows, some ups and downs that can truly affect comfort and functionality. What is palliative care? What does it do? Well, it strives to provide the comfort care that we find in hospice, but more across the entire life or disease continuum. You can find doctors within palliative care, nurse practitioners, nurses, social workers, and chaplains. If those providers are involved in palliative care, it's generally more on a sort of, it's not as routine as hospice. These aren't necessarily weekly or every other week visits, but these folks are engaging sort of staccato along the way of your journey and offering and adding support and guidance along the way. When would you look for palliative care? Definitely upstream from hospice. You'll often hear palliative care as referred to the service that's any age and any stage, meaning that palliative care is truly trying to separate itself from end of life and let the population know that it can be applied to anyone who is dealing with a serious illness. Where can it be provided? You'll often see there will be palliative care teams in inpatient settings like hospitals. And some of our hospitals right here in our backyards have very strong, excellent palliative care teams that can consult if you find or your loved one finds yourself in the hospital with a big setback. Often you'll see palliative care provided in the home setting, visiting the home just like a hospice team would. And it is provided also in the long-term care setting, just like all the levels of care here at River Landing. So why would one want palliative care? I see palliative care as sort of a disease progression comfort care expert that can come in a consultative basis, sort of staccato, scattered along your journey, to continue to give you opportunities to ask questions, offer their expertise along the way, and give you guidance as you're trying to navigate your functional ability, your comfort, and your overall disease trajectory. They can help you, along with a full meeting of your entire family, decide, well, what are my goals? What's really important to me? And what do I need to do to make those goals happen? They can also help you develop advanced directives, which is a fancy word for all those legal documents that you sometimes need to attend to, like your healthcare power of attorney, your living will, your most form, your do not resuscitate order, all those documents that give guidance and sort of put support behind what your goals for your health truly are. They can coordinate all of the healthcare players involved in your care, communicate to those players so that everybody's informed about a discussion that they might have with you and your family, advocate for your goals and your wishes, and just provide support. I can't tell you how powerful it is sometimes just to create an opportunity for patients and families to sit down together and have a provider who's not afraid to ask some of the harder questions and give everybody in the family and the patient an opportunity to sort of talk through those things. See what people's fears are. See what people's wishes are. See if there's a way we can gather everybody together on the same page and then work forward from there. How is palliative care reimbursed? Well, it's more of a fee-for-service type payment model. So just their sort of palliative providers are really considered a specialist, just like your cardiologist or your nephrologist or your pulmonologist. They are specialists in their field of comfort care. And so your Medicare Part B will generally cover those visits by the provider to sit down and talk with you. And Medicaid and commercial insurance plans generally do as well. Sometimes a copay is involved or a co-insurance payment, depending on how the insurance is written, can be involved. But the vast majority, if not all, of a provider consult under palliative care is generally covered. And palliative providers can bill insurance for their physical exam of a patient, any symptom management that they do, and the advanced care planning and goals of care conversations that they have with patients and families. So I think this is called a Venn diagram. I think this is a really wonderful graphic that shows you a little bit about how palliative and hospice care are different, but where they meet in the middle and have things in common. And it's those commonalities that sometimes cause the confusion, but they are very different specialties of care. So you'll see on the left, palliative care is paid for by insurance or out of pocket, can be received at any stage of the disease. You don't have to be considered in your final 6 months of life. It can occur at the same exact time that you are still pursuing all of the curative treatment available to you. So one might be diagnosed with a cancer diagnosis, seeing their oncologist for chemotherapy and radiation, and meeting with their palliative care provider to help them be comfortable and navigate that journey. You don't have to depart from the curative pathway to have palliative care. And palliative care does typically occur in a hospital or community setting. We'll venture over to the far right and look at hospice care once again. This is paid for by Medicare, Medicaid, and private insurance. This is not just a fee for service. This is electing your hospice benefit, which becomes the managers of your overall plan of care with a focus and function on comfort, and it is 100% covered by Medicare. You just have to depart from and move more away from that curative pathway that you may find yourselves on before. Your prognosis to be eligible for for hospice according to Medicare is that 6 months or less window of time. As I mentioned, you cannot be utilizing curative treatment, and typically hospice is going to be provided to you wherever you live. We have found ourselves in some interesting places at times to meet folks where they live. And then the things that the two services have in common right there in the middle is to focus on optimizing comfort, reducing stress on the patient and family, relieving symptoms, and providing all that emotional, spiritual support and advocacy within the healthcare continuum and with all the other healthcare providers. So, of course, the bulk of what we do at Hospice of the Piedmont is provide hospice care, but I am pleased to share with you that we do have two very strong palliative care services, and they have two different names. There on the bottom at the left, you'll see the Care Connection. Care Connection is our home-based palliative care program. That program is delivered in the independent living level of care or in private residences in folks' homes. And we have two wonderful nurse practitioners who visit folks to provide palliative care, meeting with patients and family members. Then we have to the right there our Piedmont Palliative Care, and that is the similar palliative care program that is provided in the assisted living level of care and the long-term care setting. And certainly we are able to provide palliative care right here at River Landing and are so grateful to be able to do that. So as I close out today, that'll leave us about 15 minutes worth of time for questions if you have those. But I'll just read this slide here. A paradigm shift of viewing palliative care or hospice care as a gift instead of seeing it as giving up has the potential to change the way we experience advanced age. And I hope that after hearing me speak today, you have a clearer understanding of what hospice and palliative care both are, and that you also feel a little more comfortable in understanding how we can come alongside you and add to rather than take away from your care. So with that, I'd love to open it up and just see what questions folks may have for me about anything I've said or any services that we provide.
And if you have questions, if you'll raise your hand, I'll bring you the microphone. We're recording this. So this will be on CareMerge, and I saw a lot of you taking pictures of the slides. We're going to put the slideshow up on CareMerge too. So if your pictures didn't come out okay, we got you covered. Here you go, Carol.
I could not say quickly, but I will quickly say that my experience with hospice at a really rough time was the most wonderful way to take that time. I am grateful every day for hospice. My husband was at the hospice home, and if you got to go, that's a good way to go. There were so many wonderful things. The staff are all saints as far as I'm concerned, and it's not a morbid situation at all. It is just every good thing I can think of.
Thank you for that. And I'll share real quickly, too. I had an experience with palliative care, not here. My mother was in another town, and she took a sharp decline, and we brought in palliative. And within 3 or 4 months, she was all the way back up, and we were able to discontinue those services, and we got 3 more years with her, I believe, as a result of what they did. So don't discount the power of that, or not consider it because it's affiliated with hospice. A lot of people hear that and go, oh no, Cindy, I'm not there, but it can make a huge difference. It did for us.
Thank you so much.
Other questions? Y'all raised your hand at the same time. Get my steps in, that's good.
Well, this is not exactly a question. I am reading a book called Super Ager, and I've just become aware of another book called, it's about living. And so the distinction between lifespan and health span. And somewhere back there, I decided that my goal was to have rapid mobility rather than declining. So I'm trying to do everything I could to have a health span. And I think all of us would benefit from that concept instead of, our system is more of a sick care system than a health care. So I'm very much an advocate for that. But thank you, those were really helpful.
I really appreciate your insight there. And I think, if I could just say, as we're making our way to the next question, I think if nothing else, this talk, I hope it has empowered you to think through how you want the latter stages of your life to look. I'm not too far from Medicare myself. I'll be there in about 10 years. So, so I'm thinking about it, and sometimes when we find ourselves in hospital settings, clinical settings, their goal, there's nothing wrong with it. They have a very, very important place and role in the healthcare continuum. But sometimes when that wheel starts turning, it rolls so fast you get swept up in it. And then all of a sudden, things are happening and stuff's being done, and you're like, wait a minute. I'm not sure, had I known this is what was going to happen, that this is what I would have chosen for myself. So what I love about opportunities to share with communities just like yourselves is these talks just give you an opportunity to ask yourself, what would I want the end of my life to look like? Where would I want it to happen? Who would I want to be around me at that time? And what decisions do I need to make to advocate for myself and those wishes to make sure they happen and I don't get swept away in a tidal wave I didn't want to be in? And there's nothing wrong with the treatment tidal wave. It's just not good if it's not what you wanted. And so ask the hard questions and read the books and sort of figure out what path will get you to the place you envision wanting to be.
I'm going to give you a practical situation. My wife and I are caregiving for a brother, and he has no one else and so on like this, and he's been taking the chemo for like a year now. So when do we contact hospice to say, we need help, we need some guidance and so on like that? Because we're like going into a dark cave. We have no idea.
It's a wonderful question, especially when it's a loved one who's on the treatment wheel. You know, whether the treatment wheel is working for one or not, it's always a hard decision to step off of it. It just is. And so, to answer your question, and I appreciate it, I would say now is the time to call hospice. Not because it's a commitment. It's just a conversation. I think it gives an opportunity in space and time for patients, if they're open to it, and their loved ones who are supporting them, to talk through what a path with hospice would look like, and when it makes sense based on goals of care to start down that path. And so if you're starting to ask yourself, when should I call hospice? You should probably call hospice, because a conversation, like I say, is not going to obligate one at all. I can only speak for our hospice. I call it mine because I love it and I feel like it's mine. But Hospice of the Piedmont is, as I mentioned, we started in the grassroots not-for-profit effort. When Medicare started reimbursing what Hospice of the Piedmont did, that was great, but our mentality has not changed. We are dedicated to the care and the support of patients and families. And so these are not high-pressure conversations. These are just conversations to help folks be informed so that they feel empowered to elect hospice when they feel it's right.
So just a telephone call to you will get this thing started and bring us up to date as to what we need to do and when. Is that?
Yes, and what happens, so anybody can make a hospice referral. It is false that your doctor has to make the first call to hospice. You as a patient, you as a caregiver, you as an uncle, brother, sister, aunt, whoever, you can call Hospice of the Piedmont and say, I'm concerned about so-and-so. I think we might benefit from a conversation. When you do that, what we make a strong effort to do is reach out to the primary physician in that patient's case. It might be the primary care physician. It might be a specialist who's the most involved in that moment of time. But we would do that for you. We would reach out to the provider that you tell us about to say, Dr. Clark, I need you to know that Bob would like to have a conversation with us. And as a courtesy to you, we want you to know that we, at Bob's request, are going out to talk to Bob. And I 9 times out of 10, 9.9 times out of 10 usually, the doctors will say, absolutely, go talk, go have a conversation. And then it's up to our team of providers and the patient's providers to collaboratively decide, okay, what are the patient's goals? Are they in a treatment path that they're ready to sort of step off of? And are they in that 6-month window of time? There's that both and. If we can check both of those boxes, then we could enroll the patient right away. If we cannot check both of those boxes, maybe the patient's not ready to stop treatment. Maybe they don't, the H word, the hospice word, is more than they can take right now. Maybe they're not really believed to be quite yet in that final 6-month window of time. Then we have palliative care services that we could pivot to. And that's not high pressure either, but we could share that information. And if I had a dime for every one of these conversations I had, I could retire now. But basically, the conversations create an opportunity to sort of put a flag in the sand and say, okay, here's where I am today. This is what I know now. And then the patient gets to choose whether they want to move forward with any of the services we provide. And many times they don't in that moment of time. Sometimes they never do. And sometimes we hear back from them later.
Anybody else? Great questions. Thank you all for being here. Joanne, thank you so much. I learned a tremendous amount. We're so grateful.
Thank you. Thank you so much for the opportunity to be here.